In the previous video, we discussed cell cycle non-specific drugs. So we will be discussing here the cell cycle specific drug. I told you the drugs can act on the S phase, they can act on the M phase, they can act on G1S phase, they can act on G2M phase. So we'll go one by one. First, we'll take up the S phase, then M phase, then the other phases will deal with that. So let us start the first one, the drugs which act on the S phase. So let us discuss the drugs which act on the S phase specific drugs. The S phase specific anti-cancer drug. The S stands for DNA synthesis. Now what do you require for DNA synthesis? We require the purine, we require pyrimidine. Now what we did is we started synthesizing the fake purine and fake pyrimidine. Now what happens when the fake purine and pyrimidine enters, the DNA synthesis stops. So we have purine antagonist, we have pyrimidine antagonist, and also we have a drug called methotrexate which can block the enzyme called dihydrofolate reductase. So we'll discuss these drugs in S phase specific drugs. In S phase specific, the first one which we are going to discuss, they are called as antifolate drugs. Antifolate drugs, or we can call them as folate antagonist. The major drug very favorite for examiner is methotrexate. The name is called methotrexate. Similar to that, we have a drug by the name pemetrexate, and we have a drug called praltrexate. In all this, the most important drug they ask in the exam is methotrexate because extensively used. Pemetrexate, it is used in the treatment of, let me write the use, mesothelioma. And one more condition is non-small cell lung cancer. The praltrexate, remember it starts with P, it is used in peripheral T-cell lymphoma. So peripheral T-cell lymphoma, it is used, that is praltrexate. The three drugs in antifolate are methotrexate, pemetrexate and praltrexate. So praltrexate is used in peripheral T-cell lymphoma. Pemetrexate is used in mesothelioma and non-small cell lung cancer. But major drug you should understand is methotrexate. Now let us understand the mechanism of action of methotrexate. The mechanism of action of methotrexate, let me simplify this first. Methotrexate mechanism of action is it inhibits an enzyme called dihydrofolate reductase. Now what happens if we inhibit the enzyme dihydrofolate reductase? This will decrease the synthesis of tetrahydrofolate, the active form. Now what happens if tetrahydrofolate is not formed? Then you cannot convert deoxyuridine monophosphate into deoxythymidine monophosphate. Now if that is not formed, thymidine is not available, so there is decrease in DNA synthesis. So this is the brief mechanism of action of methotrexate. It's a brief word. If I go in detail and understand the mechanism of action, let me write the cancer cell. So this is the cancer cell. What happens inside it? Let me tell you. Now when we use methotrexate enters the cancer cell, and when it enters the cancer cell, it forms polyglutamates. It forms methotrexate polyglutamates. Now this polyglutamate is the one which inhibits the enzyme dihydrofolate reductase. So when it inhibits that enzyme, there is decrease in tetrahydrofolate, and if you decrease that, there is decrease in DNA synthesis. Yes. Second, this methotrexate also inhibits an enzyme called thymidylate synthase. Thymidylate synthase. Now if we inhibit that, that is also responsible for decrease in DNA synthesis. So two important mechanisms. It inhibits, the main mechanism is inhibiting dihydrofolate reductase enzyme. Now methotrexate also has shown to increase extracellular adenosine levels. Now by increasing extracellular adenosine level, it has shown to produce the anti-inflammatory property, as well as immunosuppressant property. So because of this increase in extracellular adenosine, it is used to treat a major autoimmune disorder. What is it? It is used for rheumatoid arthritis. So this question was asked. So methotrexate can increase extracellular adenosine activity. Now I told you anti-cancer drugs can become resistant. How the methotrexate can become resistant? Number one, the methotrexate will not be allowed entry. So the drug entry is inhibited. Second mechanism, the polyglutamates are not formed. Third mechanism is the enzymes. The enzymes will not bind the methotrexate. They become mutated. Fourth mechanism is if the methotrexate comes inside, it will be thrown out. And that is called efflux. So number one, it is not allowed inside. Number two, the polyglutamates are not formed. Number three, the enzymes will not attach methotrexate. Number four, it is thrown out. That is called efflux. So these are the mechanisms of resistance of methotrexate. Now what are the uses of methotrexate? Uses of methotrexate. We know that methotrexate is not only an anti-cancer drug, it's an immunosuppressant and also it has anti-inflammatory property. Now where do uses? The use is in a cancer called osteosarcoma. So in osteosarcoma, it has to be used with higher dose. So remember in cancers, we use methotrexate high dose. In autoimmune disorder, we use it at a medium or lower doses. But cancer, we use it at high dose. It is also used in Crohn's disease. Now what is Crohn's disease? It is called as inflammatory bowel disease. So it is an anti-inflammatory property, that's why we can use it. Then it is used in autoimmune disorder. Now how come it is helpful in autoimmune disease? You know the reason. When it is being used, it stops the multiplication of cells. The bone marrow suppression can happen, and that can also suppress the bone marrow, and that will suppress the immunity. So it's an immunosuppressant drug. Then it is also used in non-Hodgkin's lymphoma. It is used in a cancer called choriocarcinoma. Choriocarcinoma, methotrexate is a drug of choice. Again, this is a potential MCQ for it. Then it is used in ectopic pregnancy. Now, what do you mean by ectopic pregnancy? Usually, the fetus should grow in the uterus. But when the zygote or embryo, if it is there in the fallopian tube or any other places, we don't want to sustain the pregnancy. So that is called ectopic pregnancy. Many times if it is in the tube, it will enlarge and a tube may rupture and leading to peritonitis. So in that case, we have to stop the fetal growth. So then we use methotrexate to abort that. So that is called ectopic pregnancy. The autoimmune disorder is rheumatoid arthritis. It is also used in psoriasis. So you can remember by the mnemonic O cancer patient. So O cancer patient is the mnemonic to understand the uses of methotrexate. So it is an immunosuppressant, it's an anti-cancer, and it has anti-inflammatory property. So very, very important. O cancer patient is the mnemonic. Now, what is the adverse effect of methotrexate? What is the adverse effect of methotrexate? Now, methotrexate can cause bone marrow suppression. And that's the reason it is an immunosuppressant. We have discussed that point. If you are using it at high dose, very high dose, there is a chance of pancytopenia. So all the cells can come down, a condition called pancytopenia. But when you are using at normal dose, the drug has shown to produce an anemia called megaloblastic anemia. Megaloblastic anemia. So what we do? For this, we add a preformed tetrahydrofolate, that is folinic acid. So we add folinic acid to prevent megaloblastic anemia. Now, coming on to the other adverse effect, the drug is hepatotoxic. So since the drug is hepatotoxic, when we are starting the drug, you have to do the LFT monitoring. So liver function test has to be monitored. If the liver enzymes are getting elevated, reduce the dose or stop the drug. Next important thing is it can damage the GI mucosa. So GI means gastric intestinal mucosa, that can get damaged. Now what happens if it is damaged? Patient will have bleeding. So bleeding in the GIT, so patient may have bleeding and a bloody diarrhea in the GIT. So there is GI damage, so bleeding, bloody diarrhea, all those things are seen. One more important, alopecia, all the drugs produce that, so not a special adverse effect. Remember two important adverse effects, that is megaloblastic anemia and hepatotoxicity, and it's a bone marrow suppressant. These are mainly important for methotrexate. They can ask in the exam, when the patient is on methotrexate, what lab parameter will monitor LFT? Suppose he has a risk of megaloblastic anemia, what do you add? Folinic acid. So these are the adverse effect of methotrexate, bone marrow suppression, when we give high dose, pancytopenia, normal dose megaloblastic anemia, hepatotoxicity, GI mucosal damage, and alopecia. Now one more important thing they can ask you is management of methotrexate toxicity. Management of methotrexate toxicity. Now when we give methotrexate at a high dose, methotrexate can affect the cancer cells as well as the normal cells. Now cancer cells are dividing too fast. So too fast they are dividing, then what I do? I have to block the synthesis of DNA. How? By inhibiting dihydrofolate reductase. But the normal cells are not dividing too fast, so we can supplement them by folinic acid. So in methotrexate toxicity, how to save the normal cells? By supplying folinic acid, which is the preformed folic acid. So it is nothing but the tetrahydrofolate, which is taken up by the normal cells. The folinic acid is also called as citrovorin factor. It is also called as leucovorin. So this is the antidote for methotrexate toxicity. That is the antidote. Folinic acid or citrovorin and leucovorin to save the normal cells. Second important drug nowadays we are using is glucarpidase. Glucarpidase, as the name ends with ASE, it's an enzyme. So enzyme will cut methotrexate. When it cuts methotrexate, methotrexate is metabolized. So methotrexate is also managed with an enzyme, glucarpidase, but never give glucarpidase plus folinic acid. Sir, will this be advantage to the patient? It looks like that, but reason why we should not give it is glucarpidase, if I give, it will also cut folinic acid. It cuts folinic acid and the effect of folinic acid is gone. So that's why don't give them together. If you're given folinic acid, then after 2 hours you can give glucarpidase. If you give them together, glucarpidase will metabolize folic acid also. So there are two options for methotrexate toxicity. Give folinic acid or you can give glucarpidase. The next one is, since methotrexate is an acidic drug, you can remove that by alkalizing the urine. So the therapy is called forced alkaline diuresis. So the therapy is called forced alkaline diuresis. This is the method. So these are the adverse effect of methotrexate, frequently asked. So please remember, the major drug you have to remember for your exam is methotrexate. Mechanism of action is inhibit dihydrofolate reductase, and remember it is mainly causing megaloblastic anemia. You add folinic acid, it can cause hepatotoxicity. You have to do LFT monitoring. So once we are done with antifolate, let us discuss another group of S phase specific drug. They are called the purine antagonist. They are called as purine antagonists. So what we do is we give the fake one. So what are the purines? You know. What are the purines? You know. Yes, adenine and guanine. So what we did is we prepared a drug similar to that. So we have a drug by the name 6-mercaptopurine. The name itself is having purine in the name. 6-mercaptopurine. Then we have another drug called 6-thioguanine. I told you guanine is the purine. So we have 6-thioguanine. Now, these drugs are mainly used to manage leukemias. Management of leukemias. Okay. Now 6-mercaptopurine after metabolism will give rise to one more drug, and that is called azathioprine. That is called azathioprine. What is it called? Azathioprine. Azathioprine is not used as an anti-cancer drug. It is used as immunosuppressant. It is used as immunosuppressant drug, which we will discuss in the next video. Immunosuppression. So there are two drugs, 6-mercaptopurine and 6-thioguanine. One important question always comes: what is the mechanism of action? Since we are giving a fake one, so they inhibit the synthesis of adenine and they inhibit the synthesis of guanine synthesis. Since we are giving the fake purine and pyrimidine, second important, they inhibit the de novo purine synthesis. And if you inhibit that, the DNA will not synthesize, so they inhibit DNA synthesis. In simple words, remember they inhibit DNA synthesis, that's it. But one important question keeps on coming in the exam is, when you are using 6-mercaptopurine, part of it is metabolized by an enzyme called xanthine oxidase, and it is made inactive. Now, whenever we use 6-mercaptopurine, I told you they are used in leukemias. When we use 6-mercaptopurine, I told you, when you use anti-cancer drug, there is a risk of hyperuricemia. To prevent hyperuricemia, what we do, along with that, we add a drug, allopurinol, and we discussed this concept already. To prevent and treat hyperuricemia, that is tumor-like syndrome, we use allopurinol. Suppose we are adding 6-mercaptopurine and allopurinol together. Now you tell me, should I use a normal dose of 6-mercaptopurine? Should I increase the dose or decrease the dose? So what should I do with the dose of 6-mercaptopurine? Pause the video and try to answer. Yes, you are right. Allopurinol is an inhibitor of xanthine oxidase. Now if I use normal dose, what happens? The 6-mercaptopurine is not metabolized, so the levels of this increases and lead to toxicity. So if you are combining both of them together, the right approach is to decrease the dose. So when you are combining them together, combining these two, you have to decrease the dose of 6-mercaptopurine, and you can decrease it up to half to 1/4 of the original dose. Half to 1/4 you can decrease it. A very commonly asked question in exam. Sir, should we do the same thing for 6-thioguanine? Not required. 6-thioguanine is not metabolized by xanthine oxidase. For that, it is not required, so don't worry. So then we have other drugs, purine antagonist. The name is called cladribine. Now, cladribine, very commonly asked as a drug of choice for a condition called hairy cell leukemia. So this is the one which you have to mark in your books. Cladribine is a drug of choice. Hairy cell leukemia, repeatedly asked question in your exam. One more drug which is called as pentostatin. Pentostatin, I know most of you will confuse with atorvastatin, simvastatin. That's why statins has to be remembered as vastatin. It ends with statin. Pentostatin is an anti-cancer drug, and don't confuse with one more statin, cilastatin. Now what is it? Now your brain is thinking, what is it? Cilastatin is combined with imipenem to increase the duration of action of imipenem. So don't confuse that. Now coming to the pentostatin, pentostatin has shown to inhibit an enzyme called adenosine deaminase. Adenosine deaminase. And if that is inhibited, there is decrease in T cell production and decrease in B cell production. And that is also used to treat hairy cell leukemia. But the drug of choice is cladribine. Cladribine. The other drugs in this case are fludarabine. Remember the name ends with arabine. Fludarabine. Fludarabine is used to treat CLL. It is used to treat CLL. Then we have a drug called clofarabine. So it ends with arabine. Then we have nelarabine. Nelarabine. So these drugs end with arabine drugs. The drugs ending with arabine, fludarabine, clofarabine, nelarabine. Fludarabine is also used in one more, that is non-Hodgkin's lymphoma. So that is about the purine antagonist. So once we are done with purine antagonist, so the next one is what we mean by the pyrimidine antagonist. Pyrimidine antagonist. And the drug name is 5-fluorouracil. As the name suggests, it is uracil-uridine. Now, it's a prodrug. And what we do, when this enters, this will become active. That is called 5-fluorouracil deoxyuridine monophosphate. So this is the active form. So it will be fluorodeoxyuridine monophosphate. Now what will happen? It will not allow the conversion of deoxyuridine monophosphate into deoxythymidine monophosphate. Now tell me, which enzyme is responsible for this? The enzyme name is thymidine. The name is called thymidine or thymidylate synthase. It is also called as thymidylate synthase. So this is the enzyme inhibited, and if that enzyme is inhibited, uridine monophosphate will not become thymidine monophosphate. Now if that is not synthesized, the DNA will not get synthesized, so there is decrease in DNA synthesis. So see the beauty here. Now what happens is, usually the enzyme thymidine synthase should take what? It should attach to deoxyuridine monophosphate and convert into thymidine monophosphate. But what we did is we gave a fake uridine, that is called fluorouracil, and that will attach to the enzyme and inhibit the enzyme. If this enzyme is inhibited, then the uridine monophosphate will not become thymidine monophosphate. So it's a enzyme inhibition. So we are fooling the enzyme by using a fake pyrimidine. Now many times along with 5-fluorouracil we add a drug called folinic acid. Now why do we add folinic acid? This folinic acid helps in increases the inhibition of thymidine or thymidylate synthase. So that action is enhanced when folinic acid is added. So we use in regimens along with 5-fluorouracil folinic acid. Clear? Now once we know the drug 5-fluorouracil, there is one antifungal drug which has the same thing. It is called flucytosine. So an antifungal drug after metabolism will give us to anti-cancer drug, that is 5-fluorouracil, that is also being asked. So an antifungal drug flucytosine after metabolism can give rise to 5-fluorouracil. So this question was asked in the recent exam. Okay. Now 5-fluorouracil, where to use it? It is usually given in the solid tumor like colorectal cancer. It is used in colorectal cancer. And in colorectal cancer, we use a regimen called FOLFOX. Sir, what is FOLFOX? FOL stands for folinic acid. I told you why do we add folinic acid, because it enhances the activity of 5-fluorouracil to bind to the enzyme and inhibit it. F stands for 5-fluorouracil and OX stands for oxaliplatin. So this is one of the regimen which is used for. One more regimen which is used is called FOLFIRI. So here same folinic acid, 5-fluorouracil, but IRI stands for irinotecan. One of the common adverse effect which is asked in the exams for 5-fluorouracil is it can cause hand-foot syndrome. Hand-foot syndrome is nothing but the skin and the hand and foot will scale up and there will be redness. That's it. It's not a serious problem, and the drug is called 5-fluorouracil, which can cause hand-foot syndrome. Repeatedly asked question in your exam. There are two more drugs which are similar to 5-fluorouracil. The name is called capecitabine. Capecitabine, and one more drug is called Tagafor. Now these are the drugs. After metabolism, they will give rise to 5-fluorouracil. So they are like a prodrug for 5-fluorouracil. They form 5-fluorouracil, and these drugs are also known to produce hand-foot syndrome. Now, can you tell me what is the antifungal drug which can give rise to 5-fluorouracil? Yes, you are right. The antifungal drug is called flucytosine, and that will give rise to 5-fluorouracil. So these are the questions we can ask. So they had asked what drug causes hand-foot syndrome. Capecitabine is asked which antifungal drug can give rise to 5-fluorouracil, flucytosine. These questions have already been asked in your exam. Yes. So once we know this 5-fluorouracil, it is important. The other pyrimidine antagonists are cytarabine. Cytarabine is also called as cytosine arabinoside. Now, one of the important aspect about cytarabine is it is given as continuous IV infusion. So it is given as continuous IV infusion. That is also being asked. Okay. And there are two important adverse effects. Number one, it can cause cerebellar toxicity. So patient will have cerebellar ataxia. Remember the C for cerebellar ataxia. And also it produces non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema that is seen with cytarabine. Now cytarabine can be used to treat mainly leukemia. Which leukemia? It can be used to treat both myeloid and lymphoid leukemia. Myeloid and lymphoid leukemia. But only thing is, it is given as continuous infusion. This is a question asked. Cerebral ataxia is a question asked. Right? Even non-cardiogenic pulmonary edema, this question has been asked with this drug. Cytosine arabinoside, or also called as Ara-C. It is the cytarabine. It's a pyrimidine antagonist. Another pyrimidine antagonist, the name is called gemcitabine. Gemcitabine. It's a gem. It's a gem for what? It's a gem for treating a cancer called pancreatic cancer. It is used to treat pancreatic cancer. Gemcitabine. Again, this question appeared a lot of times. Please mark it. The other drugs, not so important, but they are there as pyrimidine antagonists. The name is called azacitidine, and one more is called decitabine. So these are the other pyrimidine antagonists what we have. Until now, what we discussed is S phase specific drugs. They are also called as antimetabolites. The last drug what is remaining is in S phase is called hydroxyurea. Hydroxyurea, what is the mechanism of action? It will not allow the conversion of ribonucleic acid. So it will not allow the conversion of ribonucleic acid into deoxyribonucleic acid. So there is an enzyme called ribonucleotide reductase. Ribonucleotide reductase that will convert the ribonucleic acid into deoxyribonucleic acid, and the hydroxyurea inhibits this. Now, where do you use this drug? Hydroxyurea uses. It is used in the RBC condition that is called polycythemia vera, and a platelet condition. What is it? Essential thrombocytosis. and it is used in a condition called sickle cell anemia. Sickle cell anemia. Sir, sickle cell anemia is not a cancer, then why are we using it? The reason why it is used is it has shown to increase fetal hemoglobin synthesis. Fetal hemoglobin synthesis in sickle cell anemia. That's why it is being used in this condition. The name is hydroxyurea. These are the uses: polycythemia vera, essential thrombocytosis, and sickle cell anemia. In that, it has shown to increase fetal hemoglobin synthesis. Okay, so the drugs are called as S phase specific drugs, and they are also called as anti-metabolites. They are also called as anti-metabolite drugs. So in cell cycle specific, we discussed the S phase specific drugs, and they are also called as anti-metabolites. In cell cycle specific, we will be discussing now the M phase specific drugs, and M stands for mitosis. So the drugs are M phase specific drugs. Now, what do you mean by the M phase? I told you it is mitotic phase. Now, these drugs are also called as microtubule damaging agents. Yes. Now, how do they damage the microtubule? Let us understand. To understand this, let me write a cell. This is the cell, and the cell will have centromere, and we have the DNA which has to move apart. This is the daughter DNA. So they have to move towards the centromere. So for a moment, we have the microtubule. So the dotted lines, what I am writing is the microtubule. So what happens here is the microtubules have polymerization and depolymerization. So they will integrate and disintegrate. They will contract, relax. So by doing that, they will pull the DNA apart, and there is mitosis. Now what these drugs will do, they will damage that microtubule. If you damage that microtubule, the cell division will not occur. There are certain drugs which can stabilize the microtubule. So they will stabilize it, they don't allow it to destabilize. Or there are certain drugs which will destabilize and they don't allow it to get stabilized. So the microtubule will work in the fashion, it will ask to stabilize, destabilize, stabilize, destabilize, then only they can pull the DNA apart. But certain drugs keep that stability for a prolonged period. Some drugs keep the destabilized property for a prolonged period. Let us understand these drugs. So I gave a mnemonic. The drugs are called as wheat drugs. So what is that V for? V for the vinca alkaloids. So they are obtained from the plant. That's why they are called as vinca alkaloids. In vinca alkaloid, we have the major drug, and the name is vincristine. The name is vincristine. Vincristine is also called as oncovin. So onco means cancer, vin means vincristine. Now what do? They destabilize the microtubule. They destabilize microtubules. So, and they keep that in that stage only. They will make it destabilize. They don't allow them to stabilize. So like that they damage, and the drug is called vincristine. The specialty of vincristine is the drug is bone marrow sparing drug. Bone marrow sparing drug. It is also used in a childhood tumor. Used in childhood tumor. For example, Wilms tumor it is used. Wilms tumor. And it is also used in lymphomas. And I have told you the regimens for that. Lymphoma, particularly the R-CHOP regimen. Now tell me, where to use this R-CHOP regimen? It is used in non-Hodgkin's lymphoma. So O stands for oncovin, which is nothing but vincristine. So vincristine, does it have any adverse effect? Two important adverse effects with vinca alkaloids. They produce the peripheral neuropathy. So they can produce peripheral neuropathy, and they can produce SIADH, syndrome of inappropriate antidiuretic hormone secretion. That is the main toxicity with vincristine. Then we have similar drug, and that is called vinblastine. Vinblastine doesn't have that bone marrow sparing property. Vinblastine, we have discussed, it is used to treat Hodgkin's lymphoma. What is the regimen called? ABVD. So A for adriamycin, B for bleomycin, V for vinblastine, and D for dacarbazine. The drug is called vinblastine. One more vinca alkaloid is called vin or L-bine. The name is called vin or L-bine. So all of them start with vincristine, vinblastine, and vin or L-bine. The second drug, they are also obtained from the plants. They are called taxanes. Taxanes, what is their mechanism of action? They stabilize microtubules. They stabilize microtubules. Now you can remember, you pay the tax and stabilize the economy. By paying the tax, you can stabilize the economy. If you know this, if you win, you will destabilize. If you pay tax, you will stabilize. Now there are two important taxanes we have. The name is called paclitaxel. The name is called paclitaxel. The main major use is it is used in the solid tumors. It is used in solid tumors. There are two forms of paclitaxel. One is called the camphor derived, and one more is called NAB paclitaxel. What do you mean by NAB? NAB stands for albumin bound. It is called albumin bound nanoparticle. The full form is nanoparticle. So you remember AB for albumin, N for nanobound. So it's an albumin bound nanoparticle. Now the reason why camphor is not preferred because it can produce a reaction called anaphylactoid reaction. Not anaphylaxis, it is anaphylactoid reaction. So patient receiving that may develop that. How to avoid this? To avoid this, you have to give a pre-treatment. Before starting this, you have to give steroids to the patient, and also you have to give antihistamines. So that will help in preventing this anaphylactoid reaction. Now these taxanes, paclitaxels, what is the adverse effect? They can also produce peripheral neuropathy. They can produce peripheral neuropathy. This peripheral neuropathy is more with the NAB paclitaxel. This is more with the NAB paclitaxel compared to the camphor derived. So they can produce peripheral neuropathy. Then we have another taxel called docetaxel, and docetaxel is used in the treatment of breast cancer. Breast cancer. So what should I remember in this? Remember mainly their mechanism of action. Stabilize the microtubule, you pay the tax. There are two drugs, paclitaxel and docetaxel, and they can cause peripheral neuropathy. These are the points. Now in the wheat drug, I told you there are 3 E's. What are the 3 E's? E for a drug called estramostin. Now estramostin after metabolism is split into 2 drugs, estrogen and one more called normustin. Normustin, and this is used to treat which cancer? Which cancer you want to use estrogen and normustin? Is a male cancer called prostate cancer. It is used in prostate cancer. The name is estramostin. Then we have a drug by the name eribulin and one more microtubule damaging agent. These group are called apothiones. They are called as apothiones. And remember, in this group we have a drug by the name Ixa. It is called ixabepilone. So they are loans, they end with lone. Bepilone, ixabepilone. Now remember these two drugs, eribulin and ixabepilone, They are used to treat breast cancer. One of the common cancer, breast cancer, they are used to treat. So these are the weed drugs, zinc alkalides, then estramosten, eribulin, epitheliones. These three E's, they cause mainly microtubule damage. So they are called as microtubule damaging agents along with vinca and taxanes. So we are done with the next one, that is the M phase specific. Now the drug which is G1S is called etoposide. And what is G2M? G2M, we have a drug by the name bleomycin, which we discussed already in anti-cancer antibiotics. Then other drugs which are G2M specific, they are inhibitor of DNA topoisomerase. So the inhibitor of DNA topoisomerase 1. So what do you call them as? If they inhibit DNA topoisomerase 1, what do you call them as? They are called as irinotecan. And one more is called topotecan. So they end with tecan. Remember that topoisomerase 1 looks like I. So IT. So IT will inhibit DNA topoisomerase 1. Now irinotecan has some specialty. What is that? The adverse effect of the drug is diarrhea. Almost all of the anti-cancer drugs cause diarrhea. What is the treatment for diarrhea? Loperamide. And the drug undergoes glucuronide conjugation. We have discussed that in general pharma also. Moving on to the next category of drug which inhibits DNA topoisomerase 2, and that is called etoposide, and one more is called teniposide. So they end with posides, poside. And do you remember etoposide already? Yes, we had a regimen called BEP regimen. BEP for bleomycin, P for platinum, that is cisplatin, and E for etoposide. Where do you use it? It is used in testicular cancer. So these are the cell cycle specific drug. So at the end of the topic, we are aware that there is something called cell cycle specific drug. They affect a specific phase. G1S is etoposide. Then yes, synthetic or antimetabolites, we have the antifolate drugs, purine antagonist, pyrimidine antagonist, and hydroxyurea. Then we have microtubule damaging agents. G2M phase specific, they inhibit DNA topoisomerase 1. They are called irinotecan, topotecan. Two inhibitors are etoposide, tenoposide. Now in S phase, we have antifolate drug methotrexate. Remember that it inhibits the hydrofolate reductase. Major toxicity is hepatotoxicity, and it can cause megaloblastic anemia. We have to supplement folinic acid. What is the antidote for methotrexate toxicity? It is called folinic acid, citrovarum factor, or leucovorin factor. And there is an enzyme called glucarbatase. In toxicity, we make the urine alkaline. It is called forced alkaline diuresis. Now, once you are done with that, the next drug they will ask you is the combination of 6-mercaptopurine with allopurinol. So when you combine them, what should we do with the dose of 6-mercaptopurine? You have to reduce the dose. 6-mercaptopurine will give rise to a drug called azathioprine, which is used as immunosuppressant. Cladribine is a drug of choice for hairy cell leukemia. Fludarabine is used in non-Hodgkin's lymphoma. Coming to pyrimidine antagonist, we have a drug by the name 5-fluorouracil, which is a prodrug. It inhibits the thymidine synthase, and the effect is enhanced by folinic acid. So most of the regimens we add folinic acid with 5-fluorouracil. There are drugs called capecitabine as well as Tagafor, which can give rise to 5-fluorouracil, and one of the problems with 5-fluorouracil is hand-foot syndrome. Cytarabine is given as continuous IV infusion. It can be used for leukemia and myeloid as well as lymphoid leukemias. But the problem is two C's. One is cerebral ataxia and one more is non-cardiogenic, non-C pulmonary edema, non-cardiogenic pulmonary edema, that is repeatedly asked. Gemcitabine, a gemful drug for pancreatic cancer. Then moving on to the microtubule damaging agents, vinca alkalides. They start with Vin and they destabilize microtubules. and their main problem is peripheral neuropathy. Taxanes, they stabilize. You pay the tax and stabilize the microtubule. They are called taxanes, and their main problem is peripheral neuropathy, paclitaxel and docetaxel. Vinca, I told you, vincristine has bone marrow sparing effect. Then we have the other three is eribulin and epotheliones. They are used for breast cancer. Estamustin is used in prostate cancer. That is about cell cycle specific anti-cancer drugs. So this is in brief for you. Thank you all.